we go back into our CPR and American Heart Association updates for 2015. I went to the rollout a month ago, and there was frankly nothing particularly earth-shattering about the event because things we've been pretty well going along what everyone has found out is really the way to go. So this is an update and a affirmation of what we've been doing. And next month, when our practice sessions, we'll be doing the CPR practice again. Okay, get myself out of it, back into this. Okay. So the basic rules. As much as I realize most of you are paramedics here, the EMTs own the CPR because that's the one. They're the ones who are going to be working the patient mostly. So this will free up the medic to be managing drugs, to be assisting in airway as necessary. But the caveats are minimize interruptions in CPR at all times. Ensure proper depth of compression, and the new compression depth is 2 to 2.4 inches. Now, how in the hell can you measure 2.4 inches? Everybody knows that, and the take-home message for this is that you need to practice, practice, practice with those mannequins, or we need to have biofeedback devices on your life pack or on, actually Zoll has one that will actually prompt you when you are not doing correct depth. Now you say, well, if I don't have a Zoll or one of those, what am I going to do? Well, we're going to have to wait till Physio comes out with one, or we'll just have to keep practicing with the mannequins, which do give you the feedback when you've got the correct depth. Ensure full chest recoil, decompression, no hovering, no leaning or camping on the chest, as the Canadians say. Proper chest compression rate is 100 to 120, which means 110 is the sweet spot. So this means you use a biofeedback device. In our case, we're going to use the simple one called the metronome. Rotate compressors every 2 minutes. Hover hands over the chest during shock administration so you're ready to compress as soon as the patient is cleared. Intubate or place an advanced airway with ongoing CPR without any interruption. Place an IV or an IO with ongoing CPR. Coordinate teamwork between EMTs and paramedics. This means pit crew, and we'll get to that. So, establish unresponsive. No change for that for trained professionals. Trained professionals establish unresponsive and pulselessness. Don't waste time at it. The patient will either be apneic or have agonal rhythms. Now we're re-emphasizing that witnesses, bystanders only need to look for breathing, abnormal breathing, and they don't check for pulses because they're not trained. Now, we don't waste time at it. You don't want to spend more than about 5 or 10 seconds establishing a pulse. Begin CPR, usual way, you know how to do this, push down hard, 2 to 2.4 inches, and fast, 100 to 120 per minute. CPR is the foundation of good resuscitation. High-performance CPR improves defibrillation. High-performance CPR improves effectiveness of any medication treatments. We're going to spend a little bit of time on medication because there wasn't a lot of medication things in the changes right now. Now, we've proved for long to Aufderheide, who's a medical director back east, Wick, who's a Norwegian, and the head of the Norwegian resuscitation community, basically showed that without feedback, we think we really do good work and good stuff, but you have to continue to practice, continue to have feedback, because with observation they show that well-trained paramedics, well-trained EMTs thought they were doing really great CPR, and indeed they weren't. Compression depth, duty cycle, complete recoil were all performed significantly well, significantly less well when they were actually observed. So, and that in cases where they thought they were doing a good job and they then observed them, there were 50% of the time they weren't on the chest. So during that time, there's no flow. The likelihood of RLSC increases with higher mean chest compressions. Now, hospital studies, 90 or more chest compressions compared to people with only 72 or less compressions have a much higher return of spontaneous circulation. But there's a sweet spot there too. If you go over 130, you get considerably less. Now, do we ever go over 130? Yes, we've had, and a couple of times in the last 2 years, we've had rates up to 155 when we review the CPR files. It's probably related to 2 or 3 Red Bulls on the way out to the event, but you know, there's a significant decrease in ROSC as you go above 130. So the sweet spot, again, 100 to 120. We're thinking 110 is about right. Better compressions lead to better organ perfusion, which leads to better resuscitation. And here's how this works. And greater depth of compression equals increased likelihood of successful shock up to that 2.4. Now, what do you say? What about a great big guy? No, we can't figure that out. I mean, if you get a basketball player, you probably are going to have to, or someone who weighs 300 pounds, who's actually, 6'8", weighs 300 pounds, football player, you're probably going to have to go. Adequate compressions is probably more than 2.4 in a person like that. But for the average, we have about, the old rule used to be 1/3 of the chest depth. Compression equals organ perfusion, but decompression equals heart perfusion. When you compress, when you push hard, you increase intrathoracic pressure, which ejects blood from heart and lungs. Good compression equals forward output into the pulmonary tree, forward output into the systemic circulation. Decompression, the recoil, you decrease intrathoracic pressure. That pulls blood into the thoracic cavity, which refills the heart and lung. So good recoil, increased vacuum, if you will, increases refilling, increases forward output. There is a CPR device out there which I have not embraced because it's extremely difficult to use. I mean, if you think you get tired out doing regular CPR, regular compressions for a 2-minute cycle, there's a thing called a compression decompression CPR unit. It's like a big suction cup thing that fits over the chest, has 2 handles, and you push down and you pull up.
push down, and pull up 110 times a minute. That just, but what it does is increase negative interthoracic pressure. Now, I don't know how long one can continue to do that. Not very long. You need really a pit crew to do that one. But that has been tried in a few places, and it seems to have some advantage, except for the fact that it's expensive, it's cumbersome, it's another device. You look at this. Does this have a? I don't think it does. I don't think I have a pointer on this thing. So the bar on the far side, on the left-hand side, is a relative pressure, and it's relative pressure for the 3 or 4 tracings here. The dark red is the aorta. The blue is the right atrium pressure. The left ventricle is your yellow, and the dotted blue line is the extrathoracic vein pressures. When you push down on the chest, you increase the pressure in everything in the heart. So the right the left ventricular pressure goes up, the right atrial pressure goes up, the right ventricular pressure goes up, but it's not on the slide, and it rises to a systolic pressure as you're pushing down, and then that tapers off. There's a slow slope, and then as you get to entire decompression of the chest, there's a rapid drop off of the aortic pressure, then with a little blip afterwards. Keep your eye on that blip, because that blip keeps getting better in sequential compressions, and the right atrial pressure drops rapidly, and then you get the sweet spot on here, on the far right-hand side. The difference between the aortic pressure and the right atrial pressure is what's going to perfuse the heart. Interesting enough, that same curve exists, only at a lesser level, in the cerebral circulation, because the cerebral circulation will have a very low pressure on the venous side of the cerebral circulation. So it's the difference between the aortic pressure during diastole and the cerebral venous pressure that will perfuse the brain. So, longer pauses in chest compressions equals lower chance of positive outcome, because that curve there the aortic curve begins to sag, as you can see. It starts, if you had a long diastolic pause, that aortic pressure would very quickly approach the right atrial pressure. And you need to have a pressure of about a minimum of 15 millimeters difference between aortic pressure and right atrial pressure in order to drive blood. ROSC will not occur if you're less than 15. And so the best work we can do probably is to get people up to about a pressure of 30 to 35 with normal CPR. So longer pauses in chest pressure, you get lower chance of positive outcome because you have lower perfusion pressure. The slide here shows 3 seconds versus ultimately 15 seconds of interrupted CPR, and this was in an animal model, and these are the number of animals successfully resuscitated based on those pauses. So if you're going to maintain a 3-second pause, you had almost 100% chance of resuscitation, and then it drops off to 40% with longer. So the longer the pause preceding the shock or following the shock, the lower the chances of survival, which is why we want you to hover over the chest anticipating the shock to be delivered or the charge to be dropped, and then start CPR again. This shows what happens as you know, I tell you that, watch that little blip, this little blip that was back here. That little blip starts to pop up, and we're not 100% sure why that happens, but what happens is that as you give successive correct compressions, the aortic pressure begins to rise. Sort of like you're pumping it up, you're filling it up. So the aortic pressure begins to rise, and it keeps rising toward what would be a very good flow state. Probably a difference. You can see the difference there, and that inside line is rising also, as you can see. That's the difference between the aortic diastolic pressure and the venous pressure, which causes blood to flow through the coronaries. The minute you stop CPR, though, that aortic pressure drops. You know, it would be ideal, I suppose, in one sense, if you could maintain compressions through the shock. But we haven't quite got to that, you know, to that yet, where you can effectively maintain. Now, theoretically, you could do that with a mechanical device, because that would have the maximum amount of flow and the least amount of drop in that flow. Now, incomplete decompression equals inadequate blood volume to the heart and lungs. 75% decompression doesn't provide sufficient coronary cerebral perfusion pressure, because you don't have the vacuum to pull blood into the thoracic cavity. So inadequate decompression compromises both coronary and cerebral blood flow. Even if there's limited periods of incomplete decompression, it takes a long time to catch up. So this illustrates the coronary perfusion pressure if you have 100%, the left-hand side, the blue, the really bright blue, versus the dark blue, which is 75% compression recoil. Significant difference in coronary perfusion pressure, and also significant difference in cerebral perfusion pressure. Perfusion is the mechanism that circulates medication, and the better the perfusion, the better the circulation of the medication. The problem with CPR is that we're doing perhaps at the best 25 to 30% perfusion pressure, because that's what we can get with good CPR, and we're using peripheral veins or peripheral IOs to introduce medication. So it's a long time to get medication from a distal vein, whether it's a tibia or even an arm vein. It takes a long time to circulate if you're only got 25% circulation with good CPR. That may be why, to some extent, why some of our medications doesn't work well. Good CPR has been shown to use epinephrine as a testing. It decreases by twofold the amount of time required for epinephrine to reach peak concentrations compared to poor CPR. So, better CPR, the better we might be in circulating medications, but it also maybe is pointing us to what I'm beginning to feel we need to concentrate on
I think an IO is the most guaranteed way to get a line going in an arrest. Your orders are to start an IO if you can't find a vein within a minute. I'm inclined to think that we should do all humeral IOs in cardiac arrest, except in children. Children, they don't have enough. Babies don't have enough of a humeral head to be able to really put in an IO. But adults, a humeral IO, you get basically 1 to 2 heartbeats before it reaches the central circulation, and so that means to me 6 to 8 chest compressions will do the same thing. This particular slide just shows the difference again between coronary cerebral perfusion and CPR quality, both with good CPR and bad CPR, and also the difference if you add epinephrine to the effect, you get both, you get increased cerebral perfusion. The epinephrine is theoretically only there to raise that aortic pressure, which raises that end of it. This was one of the articles that came out from the first ROC studies, and basically we were looking at a subset of patients that had arrest and they were shocked by bystander AED versus patients who had the first shock from arriving EMS systems. And the conclusion was that if you were shocked by bystanders, and this was with or without, this was not always with CPR, bystander CPR. It's just if they had an AED handy and they put it on and it said shock and they shocked it, that was associated with greater ROSC and greater survival with good to excellent functional recovery, and also the use of less medications. Well, that makes perfectly good sense, because if you put an AED on somebody and it says shock and you shock them and they come back to a perfusing rhythm, you don't have to use drugs. That's kind of our hope. We would then like to encourage early shock. Another reason to support the PAD programs. Now, drugs. There were not a lot of information on drugs in the 2015. They're different than usual, but there's some complications, some things. And here's the first one. We're still talking about whether drugs really are proven to do anything, and this is where the science is right now. Big study, out of hospital cardiac arrest, 851 patients. Patients were randomized, either got ACLS with IV and drugs, or they got ACLS with no IV or drugs until 5 minutes after ROSC. Now that was the hardest part of this was to convince paramedics that they couldn't give epinephrine to patients. And then they got both sets got standard hospital care, routine hypothermia, went to the cath lab if indicated, etc. So what the findings were that if you used drugs, 40% had increased ROSC. Well, 40% had ROSC. 25% who didn't get drugs had ROSC. Admitting to the ICU. More people were admitted to the ICU.
30% versus 20%. But discharged alive, 10.5% in the drug group, 9.2% in the non-drug group, and alive at 1 year, 10% versus 8%. That is not statistically significant. And the reason it's not statistically significant is that the N numbers are too low. There's only 84 patients in the alive group and 77 patients in the alive group at the end of 1 year. Now you might say, well, yeah, but there are like four or five more people. Yes, that's true, but that's not statistically significant because there's no power in this study because there's not enough. Now, if they had 10,000 patients, we might see a statistically significant thing. We say, well, that's kind of confusing. Why, And then the Japanese come out with this immense study that had, almost 500,000 out of hospital cardiac arrest. And they said if you use pre-hospital epinephrine, you had more ROSC, but those patients who got it had a decreased survival and good functional outcomes within a month after the event, which means that not as many of, but if you call back into their data, it appears that, just like us, that if you survived your cardiac arrest with the first 1 or 2 shocks, you probably didn't get epinephrine. So the way to interpret this is probably if you, as you get further down the course of treatment, you need to have, well, we give you drugs, and just the fact that you get drugs means that it took longer for you to get ROSC, and it probably have worse functional outcome. Well, so here's a really current one. This is in the new studies, 2014. In this large group, cohort means group study, who achieved ROSC, pre-hospital use of epinephrine was consistently associated with a lower chance of survival, and associated, they showed dose effect, so the more epinephrine, the worse your chance of survival, and persisted despite what we did. So all patients, once again, had the same post-resuscitation hospital treatments. This one did not call out the difference between asystolic arrest and VFib arrest. Now here's, just to make us more confused, here's a very nice study, also new, 2014. This is a hospital study, but patients with non-shockable cardiac arrest, i.e. asystole, PEA, early administration of epinephrine was associated with a higher probability of return of spontaneous circulation, survival in hospital, and neurologically intact survival. So the current recommendations for 2015 from American Heart Association are in asystole or PEA and a non-shockable rhythm. Early administration of epinephrine is advised. They mean in the first duty cycle, if you could get an IV in and get that in, if you have a non-shockable rhythm, while you're doing CPR, get a line in, get an IO in, and give them a dose of epinephrine, or at least in the second. Now it's unclear, and the data is very confusing for epinephrine in VFib, but it is not recommended. The Heart Association went so far as they say, we're not recommending you give it as fast as you would in a non-shockable rhythm. There's some there's some evidence that if you give epinephrine within the first 1 or 2 shocks, that you may increase the risk of recurrent VFib. And the mechanism of that is conjectured to be you just cause the myocardium to be more irritable. So, non-shockable rhythm, get epinephrine in as quick as you can. Shockable rhythm, for right now, we will follow our usual rules. We do a shock, we do CPR, we do a shock, we do CPR. If it's still, and we get our lines in that time, if you have a shockable rhythm again, you shock, and then start doing the drug therapy. Now, what about more confirmation that pre-hospital hypothermia will chill people down, but it won't help in their neurologic recovery or in their ultimately leaving the hospital alive. So we've just said that we're not going to do it pre-hospital. We'll concentrate on hospital. We've got enough stuff to worry about out there. Okay. Something that we started a year ago now, and we've been working on it, is the PIC crew. The PIC crew is getting really good nationwide attention, as a matter of fact, and the Heart Association has said that in systems where it is possible, a PIC crew approach is preferable, and that a PIC crew can be modified to meet the needs and the personnel availability of the community. We have written that. I was just on a phone call yesterday. I'm participating with a group that's writing the national EMT protocols, and we've included everyone wanted to have the PIC crew thing put in there as a reference and a teaching point. So teamwork is the key. Collaborate, communicate, coordinate. Use the team approach during resuscitations. Many interventions can then be performed simultaneously. This is to minimize interruptions and compressions, and clear communication minimizes errors. And this means communicate and to practice communication. High performance CPR, the foundation is EMT CPR, and then you layer advanced cardiac life support on top of it in a way that enables high performance CPR. So it's teamwork, especially in a place like ours that has fire first responding crews and ambulance crews responding. They need to practice the teamwork approach, and that's what we will be encouraging next month. So it's simply an organizational method for managing resuscitation, giving predetermined, assigned position responsibilities, like I say, and that depends on what you're anticipating as personnel arrive. Now, in most places, if you have a 7-person PIC crew approach as your ideal, you're not going to have all 7 people show up at the same time. So they will be. You have to have a PIC crew that's a viable, living kind of thing. It starts out and then it adds to it. The number one quality, though, is maintaining the number one priority is maintaining high quality CPR. Minimal interruptions, no interruptions longer than 10 seconds. even to have the guy measuring how deep you're compressing. No. So you adapt it where you have fewer resources or where patient care requires it. Sometimes you can't do pit crew where you find the patient because there's not enough room in that bathroom. You have to get them out of there. Pit crew CPR is employed once you get the victim to a place where resuscitation can occur. If you have limited rescuers, CPR and defibrillation are your first priority. All the other activities are accomplished as you add additional resources. And incident command principles will be followed. First arriving paramedic is the team leader for the resuscitation. First arriving paramedic. First arriving company officer will be this is the Vancouver Fire model. They call it the fast attack incident commander, which I guess is FACE if you look at it in a. They're responsible for the non-medical management of the scene. Yeah, fake. Second arriving company officer is the strategic incident commander, doing the non-medical management from the tactical side. They remain uninvolved in resuscitation. Now, position one, the actual worker bee is here. Position one is compression. That person determines, yes, this is a cardiac arrest, so you're going to establish lack of responsiveness, pulselessness, and begin. Expose the chest, begin compression, announce, as we do, you hit 180, which is to prime the person with the defibrillator to start thinking about it, 190 and 200. Position two is the life pack person when they're the first to turn the life pack on, timestamp the beginning of CPR, start the metronome, which is built into that, apply the defib patches, charge the monitor at compression 190, interpret rhythm and shock if indicated after compression 200, alternate doing compressions if needed until additional resources arrive. Now, generally speaking, they will arrive. Position three takes the airway, bag valve ventilation after the first defibrillation. Our tendency at our position with Vancouver Fire is to insert the iGel after the first or second defibrillation. Doesn't get in the way of CPR at all. Provide ventilation on the upstroke. Attach ETCO2 monitoring suction as needed. Now, I'm going to interject one thing here because this is also what came out of the 2015. The 2015 looked at the CCC, continuous chest compression rock studies that were done, and the interpretation of those is that they found no difference, not even significant, no difference between 30-2 compressions and continuous chest compressions with interposed ventilation. And so the wisdom of the heart, because they, I'll put in my editorial here, because they came up with 30-2 compressions, which they pulled the reason they pulled 30-2 out of that dark place where we always pull things that we don't know about. They came up with a number, and they've been stuck with it ever since. And so they said, well, we recommend that you do 30-2 compressions, ventilations. But if you come from a system that has developed continuous chest compression and interposed ventilations, stick with it because it seems to work just as well. Okay, now there's still a couple of sub-studies, and Mo Dye and I have looked at the data, and we actually think that there is an advantage to continuous chest compressions with interposed ventilation. And it makes perfectly good sense if you think of what, you know, if you're doing 30 to 2, every time you get done with 30 compressions, you take a pause for, how long does it take you to get 2 breaths in? It takes you probably 4 to 6 seconds. Your aortic pressure drops to zip again. So theoretically, it makes more sense to continue compressions. They didn't make a comment on some of the continuous chest compression studies were done. They just put high flow O2, like we're putting a high flow O2 on a nasal cannula, but they did not do any bag valving during that time, 4 or 5 minutes. Just let passive ventilation occur. Any rate, whoops. Suction, attach ETCO2 monitoring. I can get rid of that. There. Now, if you need airway control, then we do intubation. If you have an I-gel in, you probably don't need any more airway control until you've got ROSC. So, intubation, if you need airway control, and you can do it without interfering with compressions. Position 4, alternating compressions. Position 5, IVIO meds. Again, I'm going to be encouraging you for the next year at least to think about doing my IO of choice in cardiac arrest and in trauma, for that matter, will be a humeral head IO. And then position 5, after the IO is started, also starts medication. Position 6, strategic ICA of safety, liaison with the family, discussing, developing the planning. Positions 7 and 8 are backup and assigned positions as needed, and that's your basic pit crew. And we can practice that. I want to see we've been working very well. I just continue to do it. I want to see the Vancouver crews, the fire crews, and the AMR crews working together and practicing this together. So this is just a schematic chart of the positions. You can see that the med kit is kept next to the IVIO. Your life pack 515 is at the top with the team leader ultimately. So after incident, we're going to be encouraging debriefing after every cardiac arrest crew, after every cardiac arrest call, and I'd like to see as much as possible that debrief occurs not only with fire, but if a debrief can be arranged with the AMR crews, that would be ideal. All personnel should review the CPR process file. And we're working to be able to get that to be downloaded immediately after the event, whether the CPR process file is at the with fire or if it's with AMR. As close as possible, I want the crews to review it, because this shows you, it'll show you how your performance was, and that'll help to do critique. So again, the 10 principles of high performance CPR, EMT's own CPR, minimize interruptions in CPR at all times, proper depth of compression, full chest recoil, proper chest compression rate, 110 is your sweet spot,
rotate compressors every 2 minutes, hover over the chest during shock administration, be ready to start compressions as soon as patient is cleared. The data from the ALP study showed that still the average across all the areas, the average time pause after shock was almost 10 seconds. Now, we've had many times where we're up to 5 seconds would be a good number. We're going to try to aim for that. Intubate or place advanced airway, the IGL, place an IV or IO with ongoing CPR, coordination and teamwork. Now, a couple of changes, couple of clarifications from the 2015 thing. For in-tidal CO2, they still recommend in-tidal CO2 on all resuscitations. Of course, they also recommend, as I do and require, in-tidal CO2 on every intubated patient. I also require it on an IGEL patient. But and they say that following in-tidal CO2 allows you to establish often return to spontaneous circulation. If you're working a patient and you have an in-tidal CO2 of 15 to 20, and all of a sudden it jumps to 32, 30, 32, you've probably got return to spontaneous circulation. Spontaneous circulation circulates CO2 and everything else 3 times more efficiently than your CPR is doing. That's just the way. Now, on the other side, but recall, we have in our thing, if you have a CO2 of 9, of less than 10, 9 or less, you can use that to help determine that, yeah, you do not have a live patient. I think their determination this time makes a little bit more sense for you and gives you a little, an ETCO2 less than 10, so 9 or less, in an intubated patient, you can also substitute IGEL for that, after 20 minutes of CPR may be considered as one component of a multimodal approach to decide termination of resuscitation, not to be used in isolation. In other words, you've got to do good quality CPR for 20 minutes. If you've had a gradual decrease of CO2 to 10 or less, and you've used all of your medications, and you've looked and you say, gosh, you know, I've got this patient intubated and I'm delivering good quality CPR. I've used everything that Dr. Whitwer says I can use in the book. I've done this, I've done that. And you've called medical control and you say, hey, I think we're failed on this one. Yes, you can leave. You can then call that patient. That helps you to decide that. And so that's a good thing. It takes some of the burden off you, I think. Now, the converse thing, which we haven't quite been able to get our hands around yet. Let's say you have a VFib patient and you've been in and out of VFib and you've been working this guy for 30 minutes and you've used every medication you can, and you're doing really good CPR, and he has a CO2 of 32. Is this the patient we should call, or is this the patient we should transport to the hospital and continue to work? That's where we're unclear about that, and I can't give you, that's where you're going to be having to call medical control and say, this is what I got. Now, we're evaluating a couple of systems and a couple where a patient like that
might be put on might be transferred to the hospital. It's almost impossible to do good CPR on the way in, you know that. But they might be we might transfer in the hospital with a mechanical piston type device, Lucas device on, and if in case like this, cardiologists have taken some of these people right to the cath lab, open coronary, and they've gotten people back. I don't know if we'll come to that yet. That's more news at 11, as they say. And what about antidysrhythmic, amiodarone and lidocaine? Okay, the ALPS study is done. We've got the data out. We've analyzed the data. I could tell you all the answers, but I'd have to kill you then. And because we haven't got the interpretation of the data yet. We haven't finished that. We're analyzing the data now. We're already writing the it's either going to be April is the date of publication already established for the New England Journal, and so it will be in that. It's a little different than I thought, but I can't tell you any more than that. It'll be, so for right now, we will do the same thing we've always been doing. We will use amiodarone if you have recurring VFib or persistent VFib, usually at about the second or third shock sequence. Now, what about mechanical CPR? It is not recommended. The recommendation of the 2015 recommendation is that mechanical CPR has not been shown to have any advantage over good quality manual CPR, except in a few unusual circumstances like what I just told you, or when it's unsafe or impractical for people to continue CPR, like in the back of a moving car, and they use mechanical CPR devices in the cath lab because you can't, if you have VFib arrest going on in the cath lab and you're trying to get in, trying to get into the coronaries, you can't have a bunch of people sitting on top of the chest doing compressions while you're trying to see on the fluoroscope where you're going. So, but they say, as a rule, they do not recommend mechanical CPR. There's no advantage. Post-resuscitation, there's no major increase, except that they are saying they're now recommending. We used to make a determination or cool someone post-resuscitation. They didn't wake up. You take them out after out of cooling at about 24 hours. If they didn't wake up in 24 hours, we figure they were brain dead. They say you can't do that. They're now saying a minimum of 72 hours after ROSC to determine what the likely status of the patient is going to be. And if they had cooling, they say probably 72 hours after you take the cooling off. So people can be in ICU now for 6 to 7 days before we would say, well, we don't think this person is going to survive. And I think we've got a couple of cases that actually talk about that. Okay, remind you of what the CPR process file looks like. All those little red strokes are your compressions. It's not rated as to depth. It's just compression. So and then the percent down that side where the big yellow arrow is showing is the orange arrow is the CPR ratio, which is the hands-on chest ratio. So over that, and it's done for each minute. Each of the bars across this way is a minute, so you, and so it's 77% of the time they're on the chest, or 100%. The average in this one would be well over 85%, which is perfect. This shows how fast the compression rate was in each minute. This one is at the high end of good, which is good. Compressions delivered over a minute. So you see, if you had only 77% of the time on the chest, instead of, even if you're ticking along at 116, you only gave you 88. But this shows you how. And then you get a little dashboard, which makes it easier to see. Compression ratio, total time, compression rate, averaged 120 in this one. Compressions per minute, averaged 100, which is about as good as you can ask for. And CPR ratio was 90%. Okay, let's take a break for a couple minutes, about 10 minutes. Because we keep getting a few patients with the life vest popping up, and you need to know how to manage this. It's a wearable defibrillator for patients at risk for sudden cardiac arrest who, for some reason, one reason or another, have not yet gotten a long-term implantable internal cardiac defibrillator. So it's a temporizing device, non-invasive. It's a garment and a monitor. The garment detects arrhythmias, delivers treatment shocks, and the monitor monitors the rhythm and contains batteries. The problem is, as the patient gets shocked by it, you can get shocked by the vest too. So don't touch the patient when the shock is being delivered. And the life vest will warn bystanders with a siren alert and then a voice command. The voice, because you get a siren that says and then the voice says electrical shock possible, don't touch the patient, or bystanders do not interfere, or something like that. Beware, beware, run. So, can you use external defibrillation while the patient's wearing a life vest? You need to disconnect the monitor from the electrode belt. Theoretically, the garment and belt do not need to be removed, but you kind of have to open the thing up. So you might as well remove it as it will come up. So what if the patient describes or feels a vibration coming from the garment? That might be good. I can't tell. But the vibration, along with alerts and voice prompts, are part of the thing, testing to see whether the patient's conscious or not. So if the patient gets, if they're trying to see if the patient's conscious, it requires the patient to press and hold the buttons to avoid the shock. The patient should have been trained for that. So here's what you get. If you get a gong alert, single tone, or it's silent, and the voice says, contact physician, or treatments can be given, call your doctor. That's just informational. That means the device is monitoring the patient, and it may be alerting the patient to follow instructions. And the instructions will be on a screen. If there's a two-tone siren alert, the voice may say, if the patient's not responding, call for help, perform CPR, or device disabled, call ambulance. That means it can't detect the ECG, or it's delivered the maximum number of shocks it's supposed to deliver, which I think is 6. If it's a two-tone with a voice that says, press response buttons, or electrical shock possible, don't touch the patient, or bystanders don't interfere, that means you back away from that one because the device is preparing to shock the patient. The patient could press, if the patient is really conscious and the device is preparing to shock them and it's just misidentifying what's going on, the patient can press the response button and disable it. CPR can be performed as long as the device is not telling you, back off. To treat the patient with an external defibrillator, this is the correct thing. Remove the life vest. Pull out the battery and remove the garment from the patient, because you're going to be shocking the patient. Okay. Our cardiac arrest protocols. Continuous compression CPR shall be maintained until ROSC or the termination of a code. Drug selection and administration will be based on the last analyzed rhythm. Don't pause compressions to confirm rhythm unless the patient becomes responsive. So if you've shocked the patient and you start doing CPR again, and in the middle of it, the patient grabs you and tries to physically remove you from himself or herself, you can stop CPR at that point and check the rhythm. So, VFib, pulseless VTAC. It's a shockable rhythm. Unwitnessed, continuous CPR for 2 minutes. Now, if it was witnessed in this protocol means you witnessed it. The other thing, if it's witnessed by a bystander and they're doing good quality CPR, you can proceed then under witnessed. But if they're doing CPR that's so-so, in your opinion, do your 2 minutes of CPR. So 2 minutes of CPR, or if you witnessed it, defibrillate immediately, then 200 joules. Escalate as required. Now, the real rule on this now is Heart Association 2015 says, follow manufacturer's recommendation. The manufacturer, and in our situations, the LifePak 15s, LifePak, almost, a lot of our AEDs out there are LifePak, so physio control, and they recommending starting at 200 and then move up. Now this is a biphasic waveform, and the machine is actually made to get biofeedback, get feedback, resistance, chest resistance, impedance, etc., and to figure out its own numbers no matter what you dial in. So, but they say that their recommendation is to start at 200 and then move up. And the machine will be delivering what it needs. Now, Heart Association says if you don't know what the recommendation of the manufacturer is, it's reasonable to start at full output of the machine. Well, because we know what our machines do, we start at 200 joules and escalate. Now, for cardioversion, they're now recommending 150 joules for AFib. But starting at 100 for VTAC. They're just trying to continually confuse us. So follow our recommendations. Now, so we'll shock, IV, iGel, ET tube if indicated, high flow O2 are, once again, my preference is the first person who arrives puts a nasal cannula on, runs at 15 liters high flow O2 nasally, whether or not you're going to go to an I. As soon as you go to an iGel, you do 100% O2. Now, the recommendation, clear recommendation from the Heart Association is highest flow O2 possible during CPR. As soon as you get ROSC, titrate back down to 94 to 99% O2 because of the problems with basically with oxygen toxicity if you go over that with the after ROSC. Now, drug therapy, with each drug you give, CPR for 2 minutes and analyze, defibrillate. So epi, milligram, IV or IO, in non-shockable rhythm as fast as you can give it. In VFib, I wouldn't give it until you're at probably the second or third round of CPR. If VFib or pulseless VTAC persists, amiodarone is our drug of choice, 300 milligrams IVIO. You can repeat it if you continue to have pulseless VTAC in 3 to 5 minutes. Pulseless VFib or VTAC. If you suspect torsades, or if you suspect a magnesium deficiency for one reason or another, mag sulfate bolus. Continue CPR, analyze, and defibrillate. Epinephrine can be repeated every 3 to 5 minutes. If ROSC, maintain your O2 sat of 94. It says 96. I thought I changed that, but it says it's 94 to 99. ETCO2 of 30 to 40. Monitor waveform. In asystole, continue CPR for 2 minutes. IV, ET tube. You can think about a pacemaker if the patient had bradycardia when you got there and then converted to asystole, or if you had got asystole after you gave adenocard. Drug therapy, epinephrine, milligram, repeated every 3 to 5 minutes, given it as quickly as is reasonable in the asystole. Monitor effectiveness of CPR, etc. Follow appropriate protocols if you get ROSC. PEA, continue CPR for 2 minutes. iGel, IT tube, etc. Epinephrine, if witness, consider pacer if you had bradycardia to start with. Monitor effectiveness of CPR. Now, here's your reasons. They're not all, and they're the H's and T's. So hypovolemia, any of your asystolic or PEAs, particular PEAs, we want to give a fluid challenge. In a cardiac tamponade, we just drive fast if you think there's cardiac tamponade, because we don't have the needles to do cardiac tamponade decompression, because we never have done it. So we don't need to worry about it. Tension pneumothorax, simple needle decompression. Hypoxia, you ventilate, so recheck and recheck. Drug overdose, there are a few antidotes, as we know. Hyperkalemia, follow the hyperkalemia protocol. During a cardiac arrest, we had a discussion about this yesterday, because you're already, you probably don't need to consider using the albuterol in the cardiac arrest, because you're already having a difficulty. You know, if people are spontaneously breathing, that's really easy to give them the albuterol then. It can be done. You won't get in trouble with it. It's just probably mechanically it's much easier just to give the drugs. You've already got an IV in, so just give them the drug with, just give them the calcium and the bicarbonate. Acidosis, ventilate primarily. We really don't treat acidosis with sodium bicarb. Bicarb is still, just there. Massive AMI, pressure agents, fluids. So if you have a cardiogenic shock, best thing to do is to do dopamine or epinephrine drip for the cardiogenic shock, and along with some fluids. Massive pulmonary embolus, prayer works pretty well, but embolectomy and TPA, IV TPA is still a good possibility. So that patient needs to get to the to the ED and get into the cath lab, but with IV TPA usually on the way. Hypothermic patients. This is one of the possibilities where people consider a mechanical compression device might be helpful, because you've got prolonged CPR going on until they warm them up. I mean, that person gets warmed up generally now by extracorporeal heart bypass pump. Post-resuscitation, intubate. If they're not already intubated, maintain the airway, titrate oxygen to 94, 99, maintain EtCO2 at 35 to 40. If you have persistent hypotension, fluid challenge, dopamine, epinephrine. 12-lead EKG, STEMI identified. You follow routine STEMI protocol. It's just that they're not likely to be able to chew your aspirin for you. So, basic, straightforward thing, no major change. We'll have a little bit more to say when we get done with the ALP study.
Go back one slide, please.
Boink.
Dopamine, is that an increase in our dopamine? It was 2 to 10?
Yeah, 5 to 10. 5 to 10 because you really, 2 to 10 is increases renal flow, but you really need a little bit more to get pressure up. It's also good for heart rate at that level. But epinephrine would be almost my drug of choice because it bumps their heart rate and bumps their blood pressure. It's very nicely controlled too. But either one works. We have a case in the case reviews, which we'll talk about with that. All right, just a reminder that we do have one study continuing going on here, which is the SUD study, which affects mostly AMR, but you know it helps for fire to know that too. It's all patients with pre-hospital cardiac arrest, even if you have ROSC. We don't take traumatic or violent deaths, or so if a guy is really agonizing, I suppose, before he dies, no. Traumatic death. Overdoses we don't want. And procedure is draw blood as soon as feasible after the IV or IO start, and the blood, label the tube, patient's number, EMS number, data service. Put everything in a baggie, give it to the ambulance cooler, put it in the fridge at headquarters, AMR headquarters. Hospital face sheet if you have one, if you transported the patient. And then this is analyzed and goes into the study. So, does any, no. One thing we didn't talk about, and we have had it pop up occasionally, we've got a few patients who have LVADs, left ventricular assist devices, in there. Now, as a general rule, I know there's one in Camas, or was one in Camas recently, and when a patient comes to an area, the fire district is notified of that patient, and they do a little bit of update. Okay. So and so you can have individual. They will give a little update or provide a video, I guess, to watch to know what to do with it. But generally speaking, when you arrive, there's pretty clear instructions on it, and they tell you to call the LVAD, control center, and they'll talk to you about it. Now, if one of them is Dick Cheney, we'll have to think about that. Let's see, EMS case reviews. There we go. Okay. Okay, Marty, you might want to come up here because I think a couple of these are yours too. So we'll see where we go. Okay. We have some cardiac and some cardiac cases. I think there's a couple of other ones too. This one? Okay. Okay. The rep post, patient drove up complaining of chest pain for the past hour. Said pain started while golfing. He took Tums.
finished his golf game, probably, you know, important things. You got to finish that game. He stopped at the station on the way home, worsening pain and odd sensation in his left arm. Pulse is 102, regular. Respiratory rate 18, respiratory effort normal, pain 6 on a 10 scale. They suspected a STEMI, inferior STEMI. He had a sinus arrhythmia, gave him an aspirin. 12 lead, suspected with a V4R, was possibly positive, blood pressure good, large bore IV started. And there's his 12 lead.
Yeah, I believe I took care of this guy in the ER, and this was fairly self-evident in terms of the distribution of the ischemia, and
you can see his V4R, which I would call positive.
yeah, and I know about golfers and fishermen. They just don't like to quit what they're doing, but this got him to seek help. So let's see what we got.
He got some...
Pressure's still okay. I guess he got some nitro. Usually that will sometimes help with pain, but if they have a STEMI, they're going to still have some ongoing pain.
Well, his pressure dropped to 108
Yeah. So
over 74, and he started at...
you got to be careful with those inferior
started at
wall
136.
STEMIs.
So that was
That-
luck.
Yeah.
I would have erred.
If they do drop their pressure with that, obviously you just give them a little fluid bolus and support it, and don't really treat with more nitro until we get them to the cath lab to stabilize their hemodynamics. Let's go on.
Now, with this positive V4R, let's have a show of hands here. How many people would have gone right to nitro, or how many people would have used fentanyl for his pain? Nitro, his blood pressure is 138, but he's got a positive V4R. Yeah, I'd back off myself, you know, preferentially. You know, but, you know, we're players here, so. Okay. All right.
Okay, so here's a summary. Basically, no relief with aspirin or nitro, but significant relief with fentanyl. He was transferred code 3
This is yours.
with a STEMI activation. And what I reviewed, it did a great job of identifying the inferior wall STEMI and activating the hospital team. Yeah, cardiologist and cath lab team took him quickly to the cath lab, where he had a completely occluded proximal right coronary artery. It was dilated and stented with good results. So they put a wire across the lesion and then put a balloon in and blow it up and reestablish flow, and then they put a stent in. And it's usually a drug-eluting stent that they place, and then they put them on dual antiplatelet therapy, usually Plavix or Effient and aspirin. So these patients that are post-op will have those things that they're supposed to take for 6 months to a year after the procedure. He had some non-sustained VTAC in the cath lab, but did well, and his peak troponin was high, 42. Echo showed a pretty good left ventricular ejection fraction at 50%, and some inferior and posterior wall, as you'd predict, hypokinesis, not akinesis, but hypokinesis, just kind of a stunned myocardium. And he went home on hospital day 3 in good condition, and on dual antiplatelet. Statins and beta blockers are standard too. They're kind of core elements for these patients. So this was a great case, and he'll be out on the links, I think, again. So
Maybe stay away from the fork links. Okay. Code 99. Fire was on detail at a rural barn investigating smoke in the area from a previous barn fire. Patient was the farmer, and two of his friends were on scene moving heavy equipment from the undamaged side of the barn, and the patient collapsed with fire still on the scene, and immediate CPR was started. Fire delivered 3 shocks via AED and had ROSC upon arrival of the ALS units.
Dr. Weber, it should be noted that there was a 2-person engine company, and they were rock stars.
Yeah, that's a very tiny group of that's a very tiny pit crew.
And they were able to communicate to us coming in, take time to still effectively give this guy treatment.
Yeah. Past medical history had bypass times 4, so quad bypass, colon cancer, diabetic. On arrival of the ALS, he's unresponsive, weighs 135, 68-year-old, groaning. So he had the fire was. The first responders were doing the final round of CPR with the ROSC. The patient was laying supine in water-soaked, grassy farmland. Airway was open and clear, spontaneous breathing with BVM assist, strong carotid pulse with weak radial pulse, skin pale and purple, cool, clammy, equal breath sounds with BVM assist, old scar in the center of chest, no range of motion in extremities, no other significant findings. So, they reported that they had shocked him 3 times, continued CPR, now have ROSC, lifted the patient to the ground, put him on the, in the ambulance with 2 riders, OPA placed with BVM assisted breathing, preparing ET equipment. SpO2 was 78. But he had very cold extremities, so your SpO2 is not going to be accurate. And he started VFib again. So they started CPR, charged at 200, delivered a shock, changed to sinus tach, and spontaneous breathing again, strong radial pulse, ET, SpCO2 was 35, lung sounds were clear, SpO2 was now 99. Placed a bariatric IO in the right leg, replaced the OPA with an NPA, bag valve assisted. He became pink, warm, and clammy. 12 lead showed sinus tach. Here report. Arrived Peace Health, strong radial pulse, unable to obtain blood pressure though, pulse rate 120, respirations 20, SpO2 98, skin pink, warm, transfer care. There's his confirmatory EKG showing his VFib. That's his post VFib. He's got some. I don't see evidence of ST segment elevation. He's got a lot of ST segment depression, ischemic type of changes, as one might well expect after a couple of VFib arrests. Did you take him?
I did not.
Okay. I guess I reviewed this one. So he immediately went to the cath lab, as one would have guessed. His previous grafts were occluded, but he had good collateral flow, and they couldn't find what's called a culprit lesion. They couldn't find the lesion that would give him, was enough no flow to say, yeah, this is probably, we should try to open this up. So they didn't open him up. They didn't put any stents in. There was nothing they could find to do stents. His troponin was 5.5, which is very high. He had hypothermia protocol for 3 days. Remember, I said, we've extended this now. We can extend the hypothermia protocol as recommended, and then we don't make a decision. And indeed, it took him 2 days to wake up. And on waking up, they thought he was kind of non-compos mentis. They thought he was not really with the program. And then over 5 days, he came right back to baseline. Now, someone raised the issue that he was a farmer, so I'm not sure what that means, but I take some umbrage at that myself. So baseline, because he came back, originally they said, well, you know, if he's going to be mentally compromised, we're not going to put an ICD in him. But on day 8, they said, you know, he's back to normal. They put an ICD in him because they didn't have any lesions to fix, and so he's at risk for another sudden cardiac arrest. So they put an ICD in him, discharged him home, and I guess that was the 10th day. And in the middle of, after he woke up, after about the 4th day, he said, oh, you know, I haven't been taking my heart meds you told me to take for the last 6 months. So they started him back on his heart meds. He was a farmer, right? So this is a really, really good case with a really, really good outcome.
At the beginning, you mentioned a fire. Was it a question of any smoke inhalation?
No.
CO or CN?
The fire had happened the day before.
Okay.
They put it out. It was just all still wet, but they were out there because there was more smoke, and the farmer and his buddies were moving the equipment.
Arrest.
And then he arrested in front of the BLS people. Okay, this is not a cardiac arrest, but this is a really, really good case. This was the kids. They were in the backyard around a fire pit, and some kid threw a paint spray can into the fire, which did what they do, and they exploded. 9-year-old female found sitting in a kitchen sink being sprayed on the head and face with cold water. Patient is able to speak, no audible stridor, has partial and full thickness burns to face and hands. Skin is hanging in strips from her face, has areas that appear melted, eyebrows are singed, and eyebrows are bristle-like. So, pulse is 116. Respirations, only 16 at that point. IV was started. Pulse oximetry is 100%. Patient was anticipated to have issues because of the facial burns. Was given some atropine preparatory to intubation and RSI, was given lidocaine, was given etomidate, given sucks, and was intubated. Intubated on a 1-for-1, it appears, and given some sedation and transported to CO2 was good, waveform was normal, given fentanyl and midazolam, and transported to the burn center with fair amount of meds. Patient was bucking the tube at one point, so was given some more midazolam and fentanyl. Maybe we have to give her some.
She bucked the tube the whole way. We ended up giving her back completely down.
Good. So tell me, why did you intubate her then? Did she have stridor? Did she have?
No, absolutely no stridor, no nothing. She had a clear airway. She was completely in shock. That her face was melted off.
Right.
And the decision was instantaneous. We're just going to tube her. We went in, and as soon as I opened up her airway, there was no anatomy. You couldn't see anything. it almost looked like a swollen sphincter. There was no
Yeah.
tonsillar pillars, there was no arytenoids, nothing.
Now,
It was-
we're not going to go into find out why he made that comparison.
It was swollen and red and had visible burns.
Yeah, well, no, that's good. So basically you intubated based on paramedic impression and the likelihood of this being a severely compromised airway.
Yeah.
And that's the way it's supposed to be done. And then by keeping the kid on, it might have been, this might be a case in the long, we'd have to discuss that, and this might be the case that, you know, I think it's appropriate to use the VEC in this, you know, to maintain, but,
She got a total of 15 of her said,
Yeah.
100 of
Right.
fentanyl, and
Yeah.
was still
Yeah, I think, you know,
curling up and fighting this.
I think this might make an argument for, maybe something like ketamine would be good, but after you've given that much, the other stuff, I wouldn't want to throw ketamine on top of it. So the VEC is okay, and then just continue with. Okay, so patient was transported to Emmanuel, or to Randall. So the patient was sedated was paralyzed with VEC. In the hospital, she was intubated for 4 days, had bacterial tracheitis, just secondary to the burn, has nothing to do with our treatment, cleared with antibiotics, hands are healing well, face will heal. She'll end up with scarring off that, but no?
We talked with the
Oh, good.
later, and they said that
Perfect.
one of the new treatments, and she's going to have minimal scarring too.
Good.
The second patient was also intubated.
Okay, here this one is. Oh, you guys anticipate me, see? Okay, so this is the SIB, 5-year-old male. Patient's burned from the aerosol can too. He has first-degree burns to the right side of his face, neck, and right arm, about 8%. Also what appears to be some hardened contents of paint can in hair and on the face. Lung sounds are clear. No redness to nares or oropharynx. No stridor. No hoarseness. Moved patient to the ambulance for further assessment. Acting age appropriate. Obtained IV access. For fentanyl administration, began transport. Upon transport, patient's voice changed and he started becoming hoarse. Says his throat hurts, difficulty talking, begins drooling. Stridor noted upon auscultation. Decision made to RSI and rendezvous with second ALS rider. Initial attempt, swelling noted around larynx and cords, unable to pass tube. After suction and ventilation, second attempt successful with a smaller tube. CO2 confirmed. We'll go through these, and so on and on. So he gets the same treatment and gets intubated. Arrived at Emmanuel, ET tube confirmed by ETCO2. So his ETCO2 was good en route, and then also upon transfer, moving him to the gurney. In the hospital, little rascal self-extubated himself, but did well with local wound care at that point. At that point, his swelling had gone down, things had improved. So, good, you know, really good job. I mean, that's the way this is supposed to go, and that's responding to what you see and what you anticipate.
Yeah, I think I was involved in this decision-making here from a medical control standpoint. It's often a difficult call, but I think your gut said this is going to end up being a catastrophe if we don't take care of the airway right now, and I think it was a very good decision. The second patient was interesting because he wasn't really as profoundly symptomatic at the time of our conversation, and then became suddenly have a critical airway situation. So that's just how fast these things can change, and it's an anticipatory thing that you have to have with the mechanism. And fortunately, these two did very well as they could possibly imagine. I think the ketamine is a really good thought in burn patients, especially for not only the anesthesia but the analgesia with and airway potential bronchospasm that may go along with that. So those are the only other two comments I would make. Great job.
Okay, this is a patient found wandering through a nearby field, mumbling to himself, stated he stumbled with some bushes, and bystanders then helped him back to the sidewalk. First responders state the patient with altered mental status responds to pain, past medical history is difficult, and patients deaf, communicates only in American Sign Language. And we speak that quite a bit ourselves, right? Arrival to scene, patients on sidewalk breathing. While attempting to determine responsiveness, patient becomes pulseless and apneic. CPR. After 2 minutes, gets pulses, responds to painful stimuli. Vital signs are below normal limits with irregular fast heart rate. Lifted to gurney to ambulance with assisted respiration. Again went pulseless and apneic. Regained pulses after 2 minutes of CPR. So this sort of goes to this. He gets an easy IO, distal tibia. Pulse was after initial pulse was 84, irregular. Respiratory rate 12. It goes to cardiac arrest. After CPR comes back, now his pulse is 119, irregular pulse, respirations are 12. They decide, well, we're tired of this, we're going to control this a little better, intubate, etomidate, sucks, ETCO2, CO2 value is 44, waveform is normal. I don't recall that he goes into another cardiac arrest, transported. So, transported code 3 to Peace Health, en route fluid bolus and Versed after the RSI, vital signs 12 leads showed AFib, care turned over to you. You wrote this one.
Yeah, I think I wrote this one. So this guy had pre-existing disease and had a dilated cardiomyopathy with an EF of only 25%, so really low baseline heart function. Came in with essentially a non-STEMI with low troponin peak of just over 1. And an echo showed really poorly functioning left ventricle at about 15% on the initial echo. I think it improved after that. Shockingly enough, he had methamphetamine in his urine drug screen. Can you imagine that? It must be in the water. He has improved. He had improved after waking up and extubated in the ED. He was an AFib. So in terms of the management of the case and getting a return to spontaneous circulation, that was excellent. A response by the crew.
Okay. This one is right after Christmas, right the 29th, I guess, so it's pretty current. Husband says the patient went to the bathroom where he heard something crash to the floor, which turned out to be her. He found her on the floor, barely conscious, no past history, no previous complaints. On arrival, patient was sitting on the toilet, being evaluated. Fire had arrived. Patient was incontinent, had vomited. GCS was thought to be 14, appeared to be in distress. She was conscious and able to follow commands, but she wasn't mentating correctly. She was very confused. EKG showed a sinus bradycardia with what was interpreted as being an inferior MI. Went code 3 as a STEMI alert to Peace Health. Aspirin was not administered due to questionable ability to take oral medication, i.e. the patient, they weren't sure she could chew it or swallow it. So on arrival, GCS is 14. Pulse is 36. Regular pulse strength. Respiratory rate, her blood pressure is 120/86, although her pulse is 36. 12 lead is done. Suspected inferior STEMI. O2 sat was 92%. They did a V3, V4R along with this and gave her some oxygen and transported. And here is their 12 lead, two 12 leads, one with the V3, V4R, which is, by the way, positive, and one showing obvious inferior MI pattern. But what else does this show? What else might we consider treating in this case? Yeah. And by the way, her next blood pressure, I don't know if we have it on this one, her next blood pressure, we don't have many blood pressures on this. Her blood pressure on at the emergency department was below 80.
Is there a summary on that one?
Yeah, I did the summary on this one. Any rate, I'll get to my summary here. Oh, I'll tell you my summary because I did the, okay. So the patient has a blood pressure of 80. So what should have been given to this woman for her 15-minute roughly time that we were taking care of on her transport to the hospital? Yeah. First drug of choice, atropine. Let's get her heart rate up. So, so I wanted to throw that one in to emphasize the point that and it was confirmed in the 2015 reviews that atropine is the first drug to consider when you have bradycardia, symptomatic bradycardia, for whatever reason. If you think, indeed, this lady did have a STEMI. Matter of fact, she went right to the cath lab and had her complete 100% RCA occlusion reopened, and she had a minimal bump of troponin, and she went home on the second hospital day. Just fine, just normal, just back to normal with a good stenting. Her trip to the cath lab was delayed by what? Delayed by her heart rate and her hypotension, which occurred.
Several years ago, we got to have a talk, me and you, about giving atropine to someone with a MI. And back then it was
Yep,
choice pacing was being considered over.
we agree. Back then, that was the choice.
So I'm clear now.
Yep, and that's why we bring it up today. Just so that no, you won't. And actually, atropine, for the last 2-3 years, we have been saying, you know, use atropine while you're anticipating if you maybe are going to have to put external pacing on. External pacing is really problematic. It hurts like hell, and you can't tell what's going on with the patient half the time. So, so really, we're back to the good old days of thinking about atropine, and what happened with this, she got 2 doses of atropine, and it didn't materially affect her. She still was quite hypotensive. She ran around 70, and was not really responding well to the atropine. And so they started a dopamine drip on her at about 10 mics per and got her up to above 90 and a heart rate of about 56 to 60, which is fine. They took her to the cath lab, had no problem at all opening that up, and she came back just lickety-quick. She had this is a fairly young woman, she had absolutely no history of cardiac disease or any reason to suspect it, but she sure had it. So, I mean, she got to the hospital promptly. The confusing thing is her blood pressure to start with is 120 over something, even though at that lousy heart rate. But she was so confused that they couldn't give her oral medications in the field, so basically you had to do something about that. Even though 30 times a minute she was having 120 blood pressure, but that wasn't enough to adequately perfuse her brain, so treat that. So she was symptomatically bradycardic, should have been treated. She did well, so not a bit, but it's a good thing to emphasize. Start out thinking with atropine, do the simple, it's quick, it's cheap, it's easy, before you have to go to other stuff. If it doesn't work, do the other things. Okay. All right. Thanks, guys.